Hi, Dr. Peckmadian. Sorry, move this around.
Hello.
How are you?
Doing well. How are you?
I'm good. I'm good.
Good.
Thank you all for stepping in today because it's an all USA affair today. So thank you to Dr. Mari for stepping in, helping us out.
Oh, okay. She's doing a case presentation.
She is doing a case.
Okay. Okay.
Yeah, so Augusta had the case and they just couldn't find anyone that could present.
Okay.
So I sent something out to all of the people who had previously presented a case that they would ask if they would want to or be willing to present a follow-up, and she responded immediately, and so very appreciative to her for that.
Yeah.
She did not have to do that.
And so we're still doing our case is it for June, I thought maybe?
Let's see, I think you all have it again. You do have June 10th, yes, ma'am.
Yeah, case.
I can see if maybe, let me see if I can get someone that can take that. Maybe St. Jude's, theirs was canceled. So let me see if maybe they could present
And let me know
on that day.
because I had started working on a case, but just let me know.
Oh, okay, so you've already started it. Okay.
I mean, it's not finished, but I've started. Just let me know.
Okay, I will. Yes, ma'am. Yes, so I had reached out to Dr. Nadine last week and then again earlier this week. Had you been in communication with her?
No, I have not. I hope she's able to join us for her presentation.
Yeah, it's
Hope she's able to join us. I'm multitasking while I'm talking to you. I'm sorry.
Yeah, that's okay. I'm gonna catch this call real quick, so
Okay.
I'll go on mute. Okay. Bye. Hi.
Welcome, everybody. We'll give everything just another minute or so. Welcome, everybody. I'm looking for both our case and didactic presenter. I know Dr. Mari, who's presenting our case, may be running slightly late. I'm not sure I see our didactic presenter. While we're waiting, I'll pose a case that just came across my desk this morning for thought. This is not a sickle cell case. I'll just say that up front, but while we have 2 minutes of waiting time, this is a 20-something-year-old healthy female with hereditary elliptocytosis who went to an outset hospital several days ago with what was said to be a very inflamed gallbladder. She had a cholecystectomy, but since that time has had rising bilirubin levels, more direct than indirect, and today has associated abdominal pain, nausea, and itching. Her bilirubin has now gone up as high as 27. Total bili is 27, and her direct is 20. A few days ago, a HIDA was negative, and they don't think it's obstructive, which I still think it is, and certainly there's some component that's hemolytic. Any other thoughts?
I mean, with the direct that high, can it be anything other than obstructive?
That was sort of my thought process as well.
I mean, I don't know what I don't know about the liver and its allies, but I can't think of anything else that would cause a direct that high in that type of patient. Some other kind of hepatopathy situation, I don't know.
That's the person, Dr. Atta asking about the MR ERCP. They were all set to do an ERCP, and then they said they weren't going to do it because the previous scans showed no obstruction. I disagree. I think they should still do the ERCP, and I'm confused as to why they're not. Apparently, they told the patient that she might just need a liver biopsy, but I don't know what they'd be looking for. And then they said it might be autoimmune, but that would still be a more indirect than direct hepatopathy. Okay, I'm going to tell them you said so about the ERCP, because I agree. I'm also backseat driving, but trying to help as much as possible. My benign heme colleague on. But unlike most of the sickle cell patients, I can't just butt myself in. All right, I'm trying to see. I don't see Dr. Marie yet. Who's doing our case? Do we have Dr. Razeq here yet?
Dr. Pakmadian just put in a chat box that she just texted Dr. Nadin to check on her.
Okay. I don't see that in the chat.
It's a direct message.
Ah, got it. Okay. Hopefully they'll be joining soon. Anybody else want to share an interesting case?
I have something that it looks like not to be sickle cell related. I have a lady who was referred to me with avascular necrosis of both her hips. So they wanted to see if she had sickle cell, and she also had shoulder pain, and she has AVN of her left shoulder, and her electrophoresis looks like she doesn't have sickle cell.
Does she have trait?
She has nothing. A completely normal electrophoresis. So I was wondering if anybody's ever seen that.
I have, and I've seen a few patients now with sickle cell trait with diffuse AVN in multiple joints, which is the only reason I looked it up, to find out that it happened in people who had normal hemoglobin.
Yeah, I've never seen it before, so I get to tell her the good news. No, she's no steroids, nothing, just like a regular
Good
healthy
question.
person. Just a regular healthy person all of a sudden had hip pain, and so I guess
Any
ortho.
long flights?
No.
The person that I had seen most recently with trait that had 3 joints, each joint actually correlated with he is now in some form of Army capacity, but he was flying overseas. And each new joint actually correlated with a flight over like a 12-hour flight of some prolonged hypoxia.
Oh, that's very interesting. Yeah, she otherwise has no medical problems other than iron deficiency, which I found was I was looking up, trying to figure out why she was anemic. But yeah.
Interesting, though.
Hmm.
Anybody else would like to share something interesting? Waiting just another minute to see if those that are supposed to present can join us. I haven't written up the sickle cell trait cases yet, so we have a very large, well, hopefully going to be a large sickle cell trait study through the National Alliance called AUNT. Stands for Achieving Understanding of the Natural History of Trait. And we've enrolled about 120 people. So we're trying to do some additional cross-sectional analyses to see if there's any correlations biochemically and genetically that are not just the sickle cell trait, but whether there's associated alpha thalassemia abnormalities or others. And we're excited because we just got additional funds to do some work, at least cross-sectionally in Nigeria as well. The bad news for all of us hematologists is we do see at least a signal. We'll know more hopefully in another year. But there is a signal that perhaps there's a few people, about 3% with sickle cell trait, that actually have more capacity to sickle than everyone else, which might not be great when everybody wants to be tested for whatever we figure out. But definitely interesting. Like if we can predict who would have a splenic infarct if they went to Colorado or something along those lines.
Hey, Julie.
Hey, Andrew.
Is there going to be an AUNT meeting before NASAC this year again?
There is. It's on Sunday. Laura emailed you.
Did she?
Yeah.
I'm about 2 months behind on emails. Can I still come even though our enrollment is paused because of our coordinator being
Of
absent?
course you can still come.
Okay, thanks. I will
And
find
for
that email. Thank you.
No problem. I'm glad you actually said that. For anybody who is interested, if you haven't seen it, our Alliance registration did go out. So if you haven't seen it, I'm happy to resend the registration to you. We had some issues with the hotel link, but apparently it's fixed as of today. So that shouldn't be an issue. So should be really good. We have a track. We have multiple tracks this year. So we have a pharmacy track, an APP track, a nursing and infusion track, a social work and case coordinator track, a neuro, psych, and psychology track, something I'm calling a how I treat or how we treat, sort of just clinical updates in sickle cell disease. And then we have a sickle cell disease for the sickle cell specialists track. So as we're moving more and more towards working on a curriculum to help train people as sickle cell specialists who may have done internal medicine or others, other specialties, family medicine, we're going to be introducing that track every year. And then ASH is after this year is not going to host their workshop anymore. So we're also looking to figure out how the Alliance can pick that up because we've already had new requests for people who want to do the workshop and ASH is not continuing it. So lots of excitement. All right, well, I don't see any of our presenters on, which is unhelpful. So I'm not going to keep everybody waiting unless anybody else has a spontaneous case they want to share or ask questions about.
I have one.
Go for it.
I have a 27-year-old with hemoglobin SS who last year developed type 3 cryoglobulinemia, a mixed cryoglobulinemia. And since that diagnosis, his hemoglobin has just continued to downtrend. He had a baseline of like about 8 to 10, and over the last year, his baseline is now between 5 to 7. And he's been needing transfusions pretty regularly when he goes into ED, but family's pretty unwilling to start chronic transfusion therapy or exchange. But just really curious if anybody's familiar with that combination of diagnoses and what other processes might be contributing to that anemia outside of kind of the inflammatory autoimmune process we're seeing.
Kidneys? Any change in renal function?
Yeah, he did initially with the type 3 diagnosis, and he had some proteinuria in the urine and was scheduled for a renal biopsy. But then all that kind of corrected when he was started on steroid therapy for a short burst. And he also experienced pericarditis soon after the cryo diagnosis and after the burst of steroids and some colchicine therapy. That also resolved. And since then, he hasn't had much renal or cardiac involvement. And that was like within the first few months of the diagnosis.
I just wonder if he's had a downtrend that hasn't recovered in his EPO production. Like, is his reticulocytosis decreased?
That's a great question. I don't recall it being so, but I have to go back and dig a little bit and look at that. But that's a great point.
I also have to go now look up type 3 cryoglobulinemia, so, Any other questions? Cases?
I have a sort of general question related to a case.
Go for it.
I have this little 7-year-old guy who we thought had hemoglobin S, hereditary persistence of fetal hemoglobin, presumed to be deletional, but we couldn't actually get genetic testing done for a lot of logistic reasons. But we did a electrophoresis on his mother, and her hemoglobin F was like 19%, and she did not have S. So, and we knew dad had S trait. So, process of elimination, we figured, oh, he's got, see him once every year or two, probably not gonna have any complications, celebrate, yay. And now he's having complications. And so I'm walking back thinking, well, does he really have deletional mutations? Or if he does have deletional, is it really just the fetal hemoglobin gene involved? Or does he have some kind of weird gamma delta beta situation? We have one other kid with a bizarre gene cluster deletion that's sort of similar, completely unrelated to mine. That made me think about it more, because my current patient is now having what sound like pain events that we can't find any other explanation for. Like, nothing else that is there could be causing pain that we have found. And so I don't know if anybody has any particular experience with trying to figure out, in the absence of gene testing, like looking at different parameters. I haven't found any great literature on, like, MCV, RBC ratio kind of stuff between deletions to figure out if there's anything I could parse from that. But
Is he inflammatory, and how much fetal does he have?
he has 44% F, 52% S, and his A2 was 3.7. When we first looked at him like 2 years ago, his A2 was 4.5, but everything else was roughly the same. And his CBC looks gorgeous. He's a little microcytic, 73, but otherwise looks gorgeous. His like CRP, ESR was negative. Like his CMP is totally fine. He doesn't seem like a super inflammatory kid. His retic is normal. He's not like hemolyzing. His bili's fine, all that stuff.
So I can't think of anything other than hereditary persistence of fetal hemoglobin that would cause that picture. I think that the functional testing that's useful is the flow cytometry, looking for pancellular hemoglobin F that you can get done at like Cincinnati. Offers it in their erythrocyte diagnostic lab. And that's probably I don't know how much it costs, but that's probably the cheapest option, less expensive than genetic testing, but still, challenging to get at times.
Yeah, the other plot twist for him is state. So we're in Indiana, and pretty much all of the peds hematology in Indiana is in the middle of the state in Indianapolis. And he lives at the top of the state, 2.5 hours away. So we have outreach clinics up there, and we can do labs and all of that stuff, but the send outs can get a little tricky with couriers and stuff from that part of the state. But I can try. I can try to do the flow cytometry, see what happens. But that's a good idea, looking for the cellular distribution, because that would have said, if it's pancellular, like that confirmed, like nothing else does that other than deletional hereditary persistence, right? That's it.
Right, and I don't think anything else causes that high of a fetal hemoglobin with, with no A. I mean, I think it's important to confirm the diagnosis because of the implications, but when you talk about someone with a normal reticulocyte count and over 40% F, I don't think there's another thing that causes it. I mean, other people have, what other diagnostic entity would cause it? The 2 is not really reliable in the setting of S with how most people measure it, either by HPLC or by capillary electrophoresis or isoelectric focusing. There's overlap between S and A2, so the quantification is not good. So I'm not sure that's helpful, but I just don't think there's another diagnostic entity that causes this that we know of.
The one other patient who sort of gave me pause for this one had a almost identical electrophoresis. She's a little bit younger, I think she's 2.5, but had hemoglobin F like in the high 40s, and she ended up having, I'm going to completely butcher this name because I'm doing it from memory. I think it was like gamma delta beta 0 thal mutation. There was some bizarre gene cluster situation. So instead of just like delta beta, it also hit some of the gamma, and it like hit the part that had something to do with like how much you would express, like the brakes were off. It's basically how I understood it from the articles I read on the other like 6 cases they found. But like, what are the chances we would have 2 kids with that sort of weird mutation in the same state, completely unrelated to one another? I don't know. In that weird mutation, I don't think it's pancellular anyway, so I think the flow cytometry would still give me some answers.
I do think this is more common than we appreciate because of inadequate not common, but more common than we appreciate. I just saw a woman who was 40 and pregnant who I diagnosed with hereditary persistence of fetal hemoglobin after she was told that she had sickle cell anemia, because that's what her genotyping identified, right? She had no normal adult hemoglobin, and they can't really tell whether you have 1 or 2 sickle cell mutations. But she had been asymptomatic, and she was 40, and of course she was a product liability lawyer.
Super interesting.
Diagnosed her were inadequate.
I have also seen the opposite, where we see people that were originally labeled as true HPFH, and they really don't, and they start having true symptoms in hemolysis as they age. They start having all the same symptoms. They're just 20 and 25.
Yeah. But the patients, those are the patients that have like 25-30% F and
Yes.
elevated retics of 5%, and in general a mild phenotype, but they don't have pancellular F. They have another cause of high fetal hemoglobin and get mislabeled because people don't understand that. Even some hematologists don't understand the differences.
No, I think that's true.
I'm talking about hematologists, not hematologist oncologists, where if someone has fetal hemoglobin, some people think that's hereditary persistence.
Right.
And it's not pancellular.
Yeah, we definitely have a lot of kids, particularly our kids up in this part of the state for whatever reason, who have point mutations in their hemoglobin F gene, and so they sit at 15% without hydroxyurea, which makes trying to figure out if they're taking it a fun job. But no, we see, I'd say I probably have a dozen or so out of my 70, 80 patients of my own that have point mutations in that. But that was back when we could do the genetic testing for free through a different program we don't have anymore, so we can't test all of the other kids that are coming now. But no, I agree. I think it's definitely more common than we think.
I see that Dr. Marie has joined, so she's going to present her case, but I will tell you, Laura, that the lab, the red cell lab at Augusta University, where Dr. Kutlar is, he's out on vacation, technically retiring, but he's coming back as what do you call that? Professor
Emeritus.
Thank you. I don't know why I can't keep that word in my brain, but emeritus. And when he comes back, he will do it for you for free. So just a thought for later.
Noted. I will write that down.
But with that, I will love to introduce Dr. Marie. We're glad you could join us, and we are ready for your case.
Hey, yes. Good afternoon, everybody. I am trying to share. Am I now disabled? Okay.
Is it letting you share?
Yeah, it's on my desktop and I don't know why I can't see it, but let's see.
Do you want to send it to me and then I can pull it up?
Yeah, it's gonna. Yeah, sending it to you right now. Hmm.
Make sure you're sharing from the right screen.
Yes, I think that's where it is. Someone might's looking at me and I am unable to. Um,
Dr. Mari, have you emailed them, your presentation? Or whatever?
yes, I
Okay,
just did.
okay.
So the only option to share is at the bottom. Like I have this green arrow where I have an option to share. I can't see my. Maybe I have too many things open.
Sonia, did you get it?
Not yet.
Oh, something's happening. There, well, we see your email.
I'm trying to see if I can open it. It's kind of weird. It's on my desktop. I'm not able to show you, but anyways, I'm gonna just see if can you all see my screen this way?
We just see your email.
Sorry. Have you received it, Sonia?
No, I'm looking. It seems like the larger files take a while, but
Make sure
looking
you're
for it.
fresh too.
Yeah.
Try opening it off your email right there, just for fun. Let's see if it opens and then you can see it. Since I can see it on your email.
I am screen sharing now. Can you all see?
Just your email.
Oh, it's really. So on my end, it says you are screen sharing.
You are screen sharing. You're just all we can see on the screen is your email. We can't see the.
How about
There you
now?
go. Now we can see
Okay.
it.
Good. All right. Thank you, everybody. Sorry about the delay, but I am here to present an interesting case. We are taking care of this patient right now, and I thought I'll just put it out there to learn what others have been doing in similar situations. And I also had an opportunity to look beyond what we know to do for acute crisis in sickle cell disease patients. So, acute chest syndrome, it's a disease that we well know from a pathophysiology standpoint and also from a clinical management standpoint in most instances. So I want to kind of present a special situation to see what you all have to additionally add. I have no disclosures. This is simply a case presentation to further my learning and also take it back to the patient for the patient's benefit. I have no financial disclosures. So this is a 16-year-old teenage boy with known hemoglobin SS who presented to the emergency department about 2 weeks ago with pain in the chest, hips, and knees for 3 days prior, which was getting worse. And in the interim, he has been to an emergency room locally. He lives about 60 minutes away. Because of his abdominal pain, a CT abdomen was done, which showed some enlarged lymph nodes, but there was no acute intervention suggested. So he was sent back home. His continued to have pain crisis with now episodes of emesis. He also notes constipation, no fever all along, no sick contacts, and he was ambulating when he arrived to the emergency room. When he came to the emergency room, he was managed with IV pain meds, and repeat imaging was again obtained, noted significant stool burden and some enlarged mesenteric lymph nodes, but no acute surgical intervention required. He was admitted for further pain management and bowel regimen. And in that process, an NG tube was placed for Miralax flush, but owing to the discomfort slash, seemingly uncomfortable pain perception in the chest, he pulled it out and he was drinking his Miralax by mouth. He also endured some anxiety at that point, but he was not requiring any oxygen. A repeat chest X-ray was done because of these symptoms that happened overnight. It suggested atelectasis, but no focal consolidation noted, and otherwise unremarkable. In about 24 hours from presenting, he developed fever, was clinically reassessed, and he was started on Razeq and other labs as pertinent at that time. And he continued to have fevers, intermittent spikes and fevers ranging from 38 to 40 degrees the Celsius, despite antibiotics and antipyretics. And we also noted that his initial serum bilirubin, which was unfortunately not fractionated, so it was a total serum bilirubin was 6, then went on to 8. And when we realized he was looking icteric, his direct was 3.9. And he continued to have intermittent abdominal pain. And his constipation, however, was relieved with the Miralax, but he developed new symptoms. So at this time, we did another chest X-ray. It again suggested worsening atelectasis, but no focal consolidation, some perihilar infiltrates, but nothing notable. In about 24 hours, he was reassessed and we'll go to the third line. In about 48 hours, with the ongoing fevers, a repeat chest X-ray was done, which prompted infectious disease consultation. Given his clinical picture, we added vancomycin to expand on his antibiotics. Because of his worsening serum bilirubin, he had a GI consultation, and ultrasound was obtained to suggesting some gallbladder stones. We did an MRCP to see if there was any cholecystitis or cholelithiasis, and there was none. And ursodiol was started. His GGT was also high, and he responded to the medication with slightly declining GGT as the days went by. Now, I just wanted to highlight, these pictures. When I mentioned he came in, initially his chest X-ray was not necessarily remarkable. It was a one view, not a great position of the patient, but nothing was notable. He's a heavy set kid, so there was a lot of soft tissue shadows. Now, the one on the right is 48 hours later after he developed fevers relentlessly. We could appreciate a bit more of a perihilar infiltration and maybe associated atelectasis. On clinical perception. He had some diminished breath sounds, but no accessory breath sounds. Now, in the meantime, he continued to endorse chest pain. So we did a CT chest to see if there was any element of pulmonary embolism, and it was a non-diagnostic study for PE. And he started requiring oxygen initially with simple nasal cannula, about 2 liters, and then quickly went on to require high flow nasal cannula with worsening chest X-ray findings, which I'm going to show you in a bit. Because of his clinical picture where his conversational dyspnea kind of ensued and he was not able to lay supine, he was transferred to the ICU. Antibiotics were further optimized to include meropenem, vancomycin, and azithromycin. Hemoglobin gradually trended from about 10.7 on presentation to 8.5 3 days into patient's illness or patient's hospitalization. To give you all an idea, his hemoglobin generally ranges between 10 to 11. So around this point, we were thinking of boosting his current medical therapy. We had also put him on maximum respiratory support in terms of respiratory toileting because he had copious secretions. Just wanted to highlight the worsening chest X-ray. 3 days into the hospital stay, he developed more basilar atelectasis, maybe a bit of consolidative process starting there, and continued to just look worse. Now, he remained on the high flow nasal cannula between 20 to 30 liters, and with 100% FiO2, continues to be febrile, and concerns for interstitial fluid collection. Now, we want to optimize further, as we all know, to get him a simple blood transfusion, or even possibly an exchange transfusion. But patient's a Jehovah's Witness, and he refused blood transfusion. And so we continued him on the maximal supportive care. Hemoglobin further decreased to 6.7 to 6.9 range. We had interdisciplinary care with the chaplain and the social work, and including the physician liaison at UIC, who agreed that in the case he's clinically worsening, blood transfusion would be the ideal next step. Patient and family continued to refuse any blood transfusion. We have obtained a court order to proceed with transfusion if he clinically worsens. But again, respecting patients' autonomy and religious beliefs, we continued with the maximal supportive care. Now, the supportive care did work. Gradually, in the next week ensuing, he had good aeration in his lungs, and he was able to be weaned off the oxygen requirement to a simple nasal cannula. But what we realized going back into his history, even before coming into the hospital, he has been given a CPAP or prescribed a CPAP monitor for nightly use, which he was not compliant with. And this was about 3 years ago, and the machine got destroyed in a house fire. And we so realized that that is what he needed in the last few days, nightly use of CPAP / high flow nasal cannula. He continued to be febrile, however, even about a week to 10 days of IV antibiotics. So we did some repeat blood work. The hemoglobin continues to be stable, about a 7 most recently, with all other parameters for hemolysis stabilized, including his bilirubin as well. And while he clinically looks better and he doesn't have significant conversational dyspnea anymore, he still is in the hospital requiring intermittent oxygen during the daytime, but definitely nightly oxygen. So going back into his past history or disease course so far, he was diagnosed at birth. We also realized beyond infancy, he did have a hemoglobin F of 30%. So he had this persistent hemoglobin F, and this was back in 2008, 2009, where hydroxyurea was not FDA approved for use in hemoglobin SS. So we continued to do regular follow-ups, very compliant family and patient. When he was young, he had routine labs, routine visits, never missed an appointment, normal TCD, and echoes per schedule. He did have simple pain crisis episodes that were mostly managed at home, but rarely required to come into the emergency room and rarely needed opioids at home. Had associated constipation on and off, some reflux issues that were managed with Zantac. At about age 5, he had a repeat hemoglobin F, and it dropped about 24.9%. Which I think is still common to see a bit of a fluctuation with hereditary persistence of fetal hemoglobin as they are aging. But he continued to have high hemoglobin F. Pulmonary function tests were done as a part of routine comprehensive care, and he was noted to have mild, large, and moderate small airway obstruction and was followed up with pulmonology. He was at routine follow-ups, we brought up hydroxyurea at about age 9 when we realized his hemoglobin F was going down slowly to 20% and then eventually to like 19% at that time. However, the patient and the family have not made a decision. Vaccinations were up to date, and as he progressed with his age, he had worsening simple pain crisis, 1 or 2 episodes of ER visits. And then there was, at about age 11, there was a longer hospital admission for left hip pain. And he was noted to have early avascular necrosis on imaging. Orthopedics were involved. They didn't want to do anything. And that was kind of what steered us into more definite discussions to starting hydroxyurea. So we started hydroxyurea at about age 11, 20 milligrams per kilo per day. Dose was escalated, but infrequently, and he tolerated well. At about age 12, he had a normal baseline MRI. That was his first MRI. And that was done in the context of him having some simple headaches, which were persisting, and neurology had started him on amitriptyline, which seemingly helped. And a baseline MRI was obtained, which was normal, but MRA showed a hypoplastic right M1 segment without any evidence of ischemia or other changes to suggest he had sickle cell disease affliction. Now, as he aged, he had a significant steady weight gain with a BMI close to 35 to 40%. And he had anxiety issues. He also had prehypertension, blood pressures higher in the range of prehypertension. Cardiology was closely following him and changing his blood pressure medicine. He had been started on Procardia or nifedipine at that point. He was noted to have a slightly elevated right ventricular pressures in the range of 25 to 30, which persisted, impaired glucose intolerance, and endocrinology had suggested he should go on metformin, but he was initially not compliant. Was also diagnosed with obstructive sleep apnea based on a sleep study, and was then prescribed a CPAP for nightly use in 2022. He was also referred for uvulopalatopharyngoplasty, but that was never pursued. Now, he reached a maximum tolerated dose of hydroxyurea 2,000 milligrams. In the interim, he actually did go up to about 2,800 maximum as we escalated based on his weight, but then we realized, well, it was too much. And, usually adult maximum tolerated dose should be about 2,000. So we kind of brought him back to 2,000. But when we reviewed back his labs and over the years, up until around that time in 2022 to 2023, he was compliant, as evidenced by nicely increasing MCVs up until 115 femtoliters. But as he went into 2023 and 24, we saw a decline in the MCV to about 80 femtoliters as baseline. Multiple, compliance discussions at every visit. He never missed a visit. And multiple, attempts with the compliance continued. And his hemoglobin F that was most recently done was now 20%. And this was done on the day of admission or day after admission. So he still continued to harbor the high hemoglobin F. Now, going back to what I think is happening with this patient is, we know he has the severe genotype, hemoglobin SS, with hereditary persistence of fetal hemoglobin, which in his case has really given him a significant advantage up until now. So I think it's still a huge plus and a huge boon. But hydroxyurea, despite having that persistent fetal hemoglobin, is still significant with its beneficial role, not just with increasing the hemoglobin F, but also its effects on the blood vessels and the improvement in the rheology, how it modifies the RBC and stabilizes the RBC, and the suppressive effects on the bone marrow to curtail inflammation. So again, as he aged, compliance was challenging. There were other comorbidities with his age, including but not limited to his obstructive sleep apnea and elevated right ventricular pressures, another end organ involvement. And again, not to forget that these kids with hemoglobin SS are not all the same. There is a huge variation and a disease heterogeneity. With all that said, just going back into the main principles of treatment. For acute chest. So I'm not going to go into the pathophysiology as we discussed that at earlier ECHO meetings, but we all know it still is a leading cause of morbidity and mortality in our patients with sickle cell disease. We ought to have a high index of suspicion when we take care of these patients because they don't come in with acute chest, and this kind of evolves during the hospitalization course when they come in with even a simple pain crisis. Largely supportive care has really helped, including oxygen, pain management, and respiratory toileting with very diligent in-center spirometry and CPAP measures or chest physiotherapy measures. Antibiotics and broad coverage, because there can always be an underlying pneumonia focus. And then lastly comes the need for transfusion, either simple versus the exchange based on individual patient characteristics and their risk of developing respiratory failure. Now, transfusion therapy, even though it's the mainstay of treatment with its benefits owing to the left shift in the oxyhemoglobin dissociation curves and, kind of helping with the whole sickling process and increased oxygen carrying capacity. However, not all patients can receive blood transfusion owing to their personal preferences / religious preferences or alloimmunization in lesser known instances. So back to our patient who's a Jehovah's Witness experiencing acute chest syndrome, treatment usually focuses on maximizing their supportive care and exploring alternatives to blood products. Now back to our case. With ongoing supportive care, he has been better, and social work is helping him with the CPAP for home. He did endorse some right hip pain transiently, which has now resolved. And again, repeat imaging showed that he has bilateral avascular necrosis, which again does not need any immediate intervention. Now, he has also been reinitiated or restarted on hydroxyurea, which was initially held at the peak of his illness. He will have a long road to recovery. As I said, he's still not discharged from the hospital, maybe another few days, but needs significant close follow-up. And this may be the beginning of future significant brain crisis. And compliance is something that we can immediately all push for with hydroxyurea, with limited ability to receive any transfusions with future crisis as this. So going back to, in such instances, when we do not have a choice to transfuse these patients with acute chest, even with all the benefits it has to offer, what are the bloodless treatment strategies that I have come across with my literature review? Now, in the year 2024, this group from Midwest has published data on a similar age group patient to our patient here, 18-year-old female who was a Jehovah's Witness, came in with acute chest syndrome, but significantly sick, known hemoglobin SS, on hydroxyurea prior. Not sure about the compliance aspect here, that was not highlighted, but they had to proceed with the bloodless supportive management, again, with all what we discussed, including high oxygen setting, non-invasive ventilation, pain management to the point PCA pump should be utilized for maximal doses of hydromorphone. And they have also seen a huge role for starting these patients on EPO, darbepoetin, cyanocobalamin, which is vitamin B12, folic acid, and iron. Now, that was something that I have seen, but I haven't really seen this kind of work, or at least proven to work. Now, over the next 6 days after this patient was given the supportive care, there was significant clinical and respiratory status improvement with the hemoglobin improvement to 4.9. The hemoglobin dropped to about 2 on presentation. So again, this highlights the strategy should be carefully weighed on a case-by-case basis. Again, the combinations and the permutations with supportive care, including but not limited to the vitamins and the vitamin B12 and the EPO, should all be weighed based on the patient individual characteristics. And again, the severity of low hemoglobin and what else is going on. And again, there's an ongoing study, and multiple groups have really laid out the safety and efficacy of EPO and other bloodless supportive strategies. Similarly, there is this other case that they have managed acute chest in a Jehovah's Witness patient, where this 26-year-old patient came in with a hemoglobin nadir of 3.1 during the course. And again, the strategy that was highlighted was how much you can optimize the supportive care. Now, the one thing that stands out here is this patient required to be intubated with mechanical ventilation and deeply sedated and paralyzed as well to minimize energy expenditure. And the hemoglobin nadir was about 3.1, and with all the supportive care, along with the deep sedation paralysis, patient's hemoglobin after a prolonged hospital stay had increased to 7.7 gram per deciliter. This patient, interestingly, also had an episode of menstruation, but the menstrual suppression was achieved with leuprolide. And so again, supportive care is still the mainstay of treatment for these patients when we are not using blood transfusions. But the deep sedation paralysis was an interesting concept. And again, this group in Chicago at UIC, Dr. Su is the senior author here, kind of reviewed the options for patients when blood transfusion is not in the books for management, and what do we do. Now, so alternatives to blood transfusion, right? So the hemoglobin, the oxygen carrying molecules. So I don't think this is quite legible, but I just wanted to highlight there are three scenarios here. So starting with the left-hand corner, so acute illness with infarction of blood, with indications for blood transfusions, including acute chest, stroke, and other multi-organ failure. Now, if transfusion is a possibility, you proceed with transfusion, but if it is not a possibility in your yellow box here, you have to come up with a cocktail to increase your RBC production, including but not limited to, erythropoiesis stimulating agents, high-dose vitamin B12, iron, and bridging non-blood oxygen carriers, like even hyperbaric oxygen is implicated. Avoid hyperviscosity, minimize energy expenditure, and decreased blood losses, including minimizing blood draws for daily labs. Again, supporting the concept of strategizing and maximizing your supportive care. Now, in patients with chronic conditions who do not want blood transfusions, for example, secondary prevention of stroke. So maximizing the utilization of hydroxyurea, dose optimization, adding other disease-modifying agents like your Endari and crizanlizumab, if they are of the age, and folate. High amount of folate up to 5 milligrams a day have also been implicated. Now, in the other setting where you have minor or major elective minor procedures, when you have to undergo general anesthesia, and as is a standard in most institutions about transfusing them preoperatively to increase your oxygen carrying capacity. If that's not an option, then you have to plan ahead of time for a few weeks prior to the anticipated surgery to do everything else that we discussed and avoid blood losses. So blood substitutes, so what are they? So they are currently being researched as a treatment option, and their main function, the molecule main function is they transport oxygen and carbon dioxide throughout the body. These agents can be produced synthetically, either by chemical isolation or recombinant biochemical technology. The short half-lives of these oxygen therapeutic agents limit their utility for chronic anemia, but they can be utilized in acute situations. So this group has also kind of highlighted two main groups of oxygen therapeutic agents. One are perfluorocarbons, which dissolve and absorb a significant amount of gas compared to plasma. So that's an advantage, but they're poor oxygen carriers and they can cause significant flu-like symptoms that have sometimes been life-threatening. Now, the hemoglobin oxygen carrier, the hemoglobin-based oxygen carriers have high oxygen affinity and they're good oxygen carriers, but their toxicity is they can carry too much oxygen, can lead to oxygen toxicity or oxidative stress and vasoconstrictive properties, especially the ones with short half-life. Now, this was kind of the beginning of the era where back in the early 2000s, where multiple groups have had experiences with these agents in a single case based or in vitro in the labs on mice studies. And different groups have tested in different scenarios. And so more recently, there is the utilization of the hemoglobin oxygen carrier molecule, which has been pegylated to have a longer half-life and also to cause less of a vasoconstriction and better tolerability with less side effects. So this product is collected from the one source. So the red blood cells are isolated from blood cells. So it's a free cell hemoglobin. So it's not a molecule within the cell. So this is combined with, in vitro, combined with carbon monoxide molecule to stabilize that hemoglobin and carry oxygen to the tissues. So the HPOC 201 product was used in a patient with sickle beta thalassemia when undergoing emergency C-section. And this patient was successfully revived post-section. Patient received transfusion. and has done well without any seemingly significant side effects. So there are these isolated case reports that have shown success in varying degrees when used for either chronic or acute indications. Now, one such study that was recently completed, HEMA-RA, one clinical trial. This is a prospective open-label multi-center trial that evaluates safety of 2 doses of this HPOC molecule in patients with acute ischemic stroke, either receiving intravenous thrombolysis or mechanical thrombectomy, or intravenous thrombolysis along with mechanical thrombectomy as standard of care. Now, the randomization is designed to be 3:1, where the accrual number on this study was 14 patients. So 12 patients have received this drug along with the standard of care for acute ischemic stroke. And the rest of the 3 patients or 3 patients have received just standard of care with placebo. Now, all groups have achieved recanalizations very well. But in the group that has received additional
Am I frozen or is she frozen?
She's frozen.
all the data here, the FDA has
Dr. Murray, I think you're freezing up on us. Yeah, I think we lost her. We're almost to time, but I did wonder if anybody had any questions or thoughts to add in. I did put in the chat, we use a lot of high dose erythropoietin in this circumstance. And usually if I have a known Jehovah's Witness individual who comes into the hospital, we have one gentleman in mind, he's in my hospital now, and he always drops his hemoglobin. So we start him on every other day erythropoietin when he gets in the door. I don't know if other people have similar.
We do. We use short-acting
Always,
erythroid-stimulating
yes.
agents because I think that they work a little faster, maybe, or a little better. And also, we can't use Darby in patients because of reimbursement. And then, especially for the people that have a religious objection to blood transfusion, we'll often think about giving them the IV iron because many of these patients have so iron stores, different than the chronically transfused people.
Sorry, Dr. Murray, we were also just chatting as we lost you that we do often start individuals with Jehovah's Witness on short-acting EPO, never long-acting when they come in the door.
Yes, and that was my last slide. I'm sorry, I actually don't know where I lost you all. I apologize. I hope I made my case here and opened the floor to discussion, which has already started. So really, I wanted to, I guess I was in the midst of this EPO discussion. So EPO is something that is utilized, even when you think about how it actually induces the erythropoiesis, and it's not necessarily a meaningful hemoglobin production or meaningful RBC mass production.
So we use it consistently. For my Jehovah's Witness patients, we actually start it when someone comes into the hospital. The minute their hemoglobin drops below 8, we put them on 40,000 units.
Okay. Okay, that's so the long-acting one or the EPO, the short-acting one?
Always short-acting. The
Always
long-actings take longer to act, and I've actually had more patients with pain with them.
Okay.
And as Dr. Strauss was just saying as well, we couldn't get reimbursed for them in the hospital.
Okay. What about experience with multivitamins, vitamin B12, high-dose folic acid, and iron?
I give IV iron. I don't give
Okay.
any of the others.
Okay. And what about your other disease-modifying agents? Any role in the, Endari, which is, the high-dose glutamine? I don't know how feasibly we can administer this to a patient who may not be able to even take it by mouth.
I don't think acutely there's a role if that's,
Mm.
I mean, that's my opinion. I don't, but there's never been any data that demonstrated acute use of Endari or crizanlizumab.
Anyone ever used high-dose oxygen or hyperbaric chamber oxygen? And arbitrarily, I've noticed that, there's really not a threshold, but there are few isolated reports about hemoglobin of 5. In a situation like this, when we were getting close to reviving this patient acutely and maybe even utilizing the court order, but we didn't quite, we had a sort of a loose discussion about, maybe a hemoglobin of 5. He's a 120 kilo kid. So any further lowering of hemoglobin up to a 5, he may not be able to go on as such without adding EPO to the mix, or without having already started the EPO or giving the IV iron. What do you think about that?
I wanted to say something about court orders and state. So, I mean, it really depends quite a bit on your state. When I was in Maryland, if we thought that the standard of care, not that it was a life-threatening situation, but the standard of care was to transfuse, we transfuse using the court order. It's very different in North Carolina, where I am now, where it needs to be life-threatening illness. But sometimes we aren't sure where, who's going to do poorly and not, especially for acute chest syndrome. I think the evidence that erythroid stimulating agents help people to recover from acute chest syndrome is very different than severe anemia.
Okay. Well, that's good. That's good to know. And any individual experiences with the HPOC molecules?
Many years ago, I used sanguinate as part of a study, and I person lived. Whether the sanguinate had anything to do with it, I can't tell you.
Right. And I believe it's a process when we want to use it for our kid.
It's still not FDA approved, right?
Correct.
Yeah.
I think you can do an application for the company, and they can, I think, give the medication for compassionate use, and they have done that in instances, yes. But yes, it is in the clinical trial for acute ischemic stroke, it was tested in patients above 18 and above. So, all right. Any questions for me?
Just one.
No, I just have one, other question, for the group, that now that he's getting better and maybe able to go home, he still has a low hemoglobin. Would it still be of value to start him on the Epogen and give him IV iron before he leaves a short acting iron, or what? Because he's still not a baseline. He's still at around like 6.9 or 7 hemoglobin, of about 5 or 6% of the retic count. That's another thing. I don't know why all through this illness, maybe it was the sepsis or the acute chest or the infection, he had been having low retic count. He's not coming up with what his baseline, should be.
What's his and you restarted the hydroxyurea, so that might be part of it. But I would absolutely give. I mean, he's still on oxygen. I would absolutely give Procrit.
Okay.
Good.
Others?
Yeah, I was gonna comment on the atelectasis. So atelectasis can be a red flag in patient who comes with some respiratory illnesses. So we usually do like very early intensive airway clearance and chest toilet to try to open that part of the lung, because this can be a slippery slope into hypoxia, more atelectasis, sickling, and can cause like hemolysis that can drop the hemoglobin. The second point is we usually start non-invasive much earlier into the course of acute chest syndrome than probably other places. So for this patient especially, I would probably start him on BiPAP as soon as he hit the PICU, given his body habitus, his history of obstructive sleep apnea, the atelectasis. So we usually start BiPAP early into the course of acute chest syndrome, because again, this can prevent the progression of acute chest syndrome and can reduce the hemolysis and other kind of effects of the atelectasis.
Regardless of the transfusion, even if this patient was not a Jehovah's Witness, would you? Yeah.
Yeah, exactly. No, any patient with acute chest syndrome who have significant atelectasis, when they need PICU, we usually start them on non-invasive early on into the course. This can help improve the course significantly. We have acute chest syndrome pathway. that we use. So there are 3 parts of the pathway. One for the ED to start airway clearance and chest physiotherapy early in the ED. The second part is for the floor, for the regular floor. And the third part is for the PQ. So the part in the PQ encourages starting BiPAP as soon as possible when the patient with acute chest pain needs to be in the PQ.
Interesting. Well,
Great.
thank you. I think that's the beauty of having a pulmonologist in-house. We have Apache pulmonology service, so we kind of are our own pulmonologists. But no, that's a great point you bring up, especially for this heavy-set patient who has already required CPAP for outpatient. Yeah. Yes.
Dr. Mark, on a different note, with hydroxyurea being so imperative, you may want to consider, particularly if he has Medicaid, they do have, Gulf Coast Total Care, which is a care coordination, service that's available that has a pharmacist, a RN that actually goes out to the home for a home visit. There may be some barriers in terms of why he went from being compliant with hydroxyurea to non-compliant with hydroxyurea that we're not aware of. And that would give a little bit of an insight, given how important now I think the hydroxyurea is in this patient's case. They've been very helpful on the adult side in terms of going out to the home, doing a home assessment. And we have found some barriers to care that we were not aware of in the home. And so just a thought, I mean, it's
that's a good
Sure,
thought.
sure.
That's a good thought. Yeah.
All right,
But thank you very
everybody,
much.
we are at time. So this was a great conversation and certainly something I think that we should continue to discuss. And thank you, Dr. Mari, for presenting such a great case. And we'll look forward to seeing everybody in 2 weeks.
Thank you all.
Thank you.